right, how's it going, everybody? Thank you so much for being here. Waiting just a couple minutes to get started. Let people kind of get logged on here. Really excited to be here. My name is Brian Lewis. I am the Director of Marketing here at OrthoFi, and we're excited. It's Friday. I know people are busy right now, but I don't know a better way to spend my Friday morning than talking about insurance with the infamous Tina Byrne. So we are going to kick things off here. Before we do that, I want just a couple housekeeping items. Obviously, we are going to be recording this, so we're going to, if you can't make the whole thing, obviously we hope you can be here, but we will try to get it shared within the next week or so. And then we also wanted to introduce everybody. There's an email that went out about it, but we're really excited to announce a live course that we're doing. So I think the content you're going to see today, you're really going to like. Tina obviously is one of the leaders in the consulting space, especially when it comes to insurance. And we're going to be doing a full day course on November 19th. So a little happy hour on the 18th and an event on the 19th. There is a QR code there. You can scan it and it'll tell you a lot of information about the event that we're doing in November. If you use promo code OrthoFi when you register, you'll save 15% on your registration costs. So we really hope you're able to join us. It's going to be really a much deeper, comprehensive dive into some of the topics that Tina's talking about today, but really going to a much deeper level. And I know it's going to be really, really valuable for our practices, even if whether you're an OrthoFi customer or OrthoBank customer, or if you're not a customer of ours, we know it'll be valuable for you, and we really think you'd enjoy it. So if you have questions, we want this to be super interactive. So please, ask questions to Tina. We're going to field those at the end. There's a Q&A function down and on the bottom bar of your Zoom controls. So please try not to send them in the chat, but if you want to chat and do things like that, that's great. But if you have any questions, we're going to field them all and then ask them. Tina's going to field all those at the end of the webinar. So with that, I'm very honored to introduce Tina Byrne. Tina's considered the orthodontic industry's really insurance expert. She's gained success and recognition for well-founded proficiencies in clinical, business, and administrative functions. She has an extensive knowledge and understanding of systems, innovation, and efficiency, data analysis, strategic business planning, and marketing implementation. So she's lectured and helped guide the success of lots of the leading practices across the country, both large and small. And we are so honored to have her be here with us, super excited to have her jump in with these things. And again, we hope you look forward to it. And Tina, with that, I'm going to hand it over to you, and thanks for being with us today.
Hey, thanks, Brian. Let me just see if I can get things in order here in terms of sharing my screen. All right, are we good to go? Well, welcome everyone, and thank you for giving me time on your Friday. Thank OrthoFi, thank OrthoBank for also giving me their time. So I'm sure everyone who's signed up for this lecture is eager to hear lots of the things I have to say today. And there is a lot to say. A couple hours this morning, we're gonna touch the surface of things. We'll dive into the things that probably matter the most to you, and I'll take your questions on them. But as Brian said, please consider joining us in November. It will be a day chock full of everything for doctors to consider, how insurance is impacting their office, for insurance coordinators and treatment coordinators, which I see we have a pretty good mix up today. So with that being said, let's get on to our keys to the insurance game. And let's see if I can get my slide going here. There we go. All right. I always like to tell this story because it kind of puts things into perspective. But you always like to start a presentation with a little story, a little anecdote, something that kind of gives you an idea of what it is that your audience is thinking. And when it comes to insurance, that's always pretty interesting. A few years ago at an AAO meeting, I began my presentation, and the room full of attendees, I said to them, can anybody tell me what they like about being an insurance coordinator or about managing insurance in your office? And it was, you could hear crickets. Nobody raised their hand. Nobody liked anything. Then I said, on the flip side of that, what is it that we dislike? It was chaos. Everyone had something that they disliked about insurance. It's not an easy part of the practice to manage. So with that being said, I just want to say this to all the insurance coordinators out there, to all the team members that are involved in insurance, that you have to realize it was never addressed. I use the analogy that you're superheroes because you fight crime and you protect the innocent. And that may seem a little cynical, but sometimes if you're deep into insurance, you know that sometimes that's exactly the way it seems. So kudos to our insurance coordinators. I think overall, the team doesn't know what you deal with sometimes, and it's ever changing, it's ever evolving. So it was never addressed, ladies. I'm going to break up this presentation today into 4 different categories. I kind of looked at the big picture of insurance and said, all right, well, how do we handle things? So here's the things that I want to do and the things we want to talk about today, the order we'll do them in. The first thing I'm going to do is talk about carriers and contracting a little bit. Then I want to go into plans and benefits because there's definitely, you have to understand the structure of each of those. We'll talk about assignment of benefit because clearly if you take assignment of benefit, you're managing your insurance receivables. So those are the 4 areas that I'm going to touch on today. And with that being said, we'll get started. But someone asked me one time if I can sum up insurance in a sentence or so. And here's the way I see it. The success of insurance, plan participation, acceptance of your assignment of benefits, your claim submission, and your follow-up in a practice is a result of ongoing education and the alignment of your methods and your mindset. And when I say methods and mindset, that is your processes. And the other thing is the way you think about insurance, because you have to be open-minded. If there's anything in a practice that's not black and white, it's certainly the insurance area of the practice. So let's get started with carriers and contracting. Contracting is when you're going in network with an insurance. I'm not going to tell you that you should be in network. I'm not going to tell you that you should not be in network, but I'm going to give you an overview for considerations because it's constantly evolving. It's an industry where carriers are setting up situations in terms of how they manage benefit plans, and the contracting is changing. So let's start with that a little bit. And for those of you that might be new, I just want to touch on how insurance breaks down a little bit. There's really 4 types of plans, 4 types of plans that a carrier will put out there. Indemnity is basically, you can go to any provider. You have a benefit maximum, it's paid by a percentage, and you have no limitations on where you can go with that insurance. It used to be years ago when I began actually working in the field of ortho and touching in the insurance within the practices, that indemnity was the majority of most people's plans. They had indemnity plans. If we look at it now, only 6% of dental insurances out there are indemnity plans. If we look at the PPOs, we're talking about 82%. And PPOs doesn't mean necessarily, I refer to it as death by discount. It's not always that situation, and I hope to show you that today as we go through some of this information. But 82% of dental plans are now PPO plans. And you look at the way carriers are advertising, pushing, whatever it is that they might be doing. I was quite shocked to come across something on social media the other day where another consultant in the dental field had a screenshot of basically what came across your telephone, like a message, and it was from Delta Dental. And it said, you could have saved money by going to an in-network provider. So apparently what's happening when some of these services are submitted the subscriber is getting messages from Delta Dental that they could have saved money by going in network within their PPO with a provider. So they're doing everything they can to promote, to look at providers becoming in network versus out of network. And that's something that we're dealing with. Another thing that's out there are the HMOs, DHMOs. Managed care, HMOs, most people are familiar with that, with the medical side of their insurance benefits. And clearly, you know, that has many restrictions. It's a closed plan. When a patient comes to you and they have an HMO or a DHMO, if you're not contracted with it, they'll have no benefit whatsoever in your office. So those are very easy to, those are very important to identify early on when you have a patient with those. The other type of plan is a discount plan. Discount plans have evolved over the years. There was a time when someone could go out and they could sign up for a dental plan. And it meant that if you had this little card, you walked into the office and you were given a discount. Well, that's changed quite a bit. If we go back to the PPO plans now, some of the PPO plans are using discount models instead of fee schedules. So we'll go over that a little bit. So those are the four types, but clearly you can see 82% of plans being PPO. There's a majority of patients coming in your door that are going to be looking, or the thought in their head about being in network. When you contract with a carrier, and this is what many doctors don't realize, is you can contract with that carrier directly, or you can contract indirectly. And basically this is the networks that are out there. In other words, the large commercial carriers are now becoming networks, third-party administrators for smaller plans. So when you contract, it's very important to look at, am I contracting directly? Am I contracting indirectly? An example would be United Concordia. United Concordia Advantage. Many offices have this plan. It's not a low-paying plan, and it's probably one of the most common that I see. There might be 3 or 4 plans that most offices will go for. I can go to United Concordia and I can contract with them directly. The other thing that you find is that United Concordia also will manage other plans under their umbrella. Assurant, Lincoln Financial, Principal. Those are plans that should you contract directly, you're going to have a very low allowance in terms of your fee schedule. Going in network with those plans indirectly through United Concordia means that all of those plans would fall under the allowance that United Concordia would give you, which is substantial. You're not taking much of a discount, if any, depending on the type of treatment that you're submitting. Another look at contracting with plans and being indirectly is there are a couple networks out there. Carrington is one of them. Connection Dental is another. And these are, for the most part, they're discount plans. But when you look at the carriers you can contract with under these umbrellas, the discount that you're giving a patient, you actually are making out better than if you would contract with a carrier directly. An example would be Cigna. Cigna is probably everybody's headache right now. I'm sure on the other end of this screen, there are lots of insurance coordinators shaking their head yes. Difficult to deal with. We'll talk about them as we go through some of the exclusions, restrictions, some of the governing that they're doing with treatment, but Cigna is notorious for that. I have offices who have contracted with Cigna indirectly through Carrington, and instead of taking a low fee and being locked into their treatment times that they're dictating, they're actually giving 10%. And when you look at 10%, I want to give you some perspective into that. Here are a couple other plans that you can go indirectly through Carrington. GEHA, Guardian, United Healthcare. GIHA is another name that we're going to talk about today, which is notorious for sticking it to out-of-network doctors, for lack of a better phrase. That's what it is. So you can go indirectly with these plans. So you have to think about it. It's not a matter of looking at what their fee schedules are. It's a matter of knowing the industry and knowing how it's evolving and knowing how it's changing. And I will say, it's a big job. I get a lot of questions. Can I negotiate fees? Can I help them contract? I could, but number one, I'm a third party. And when I've done this in the past, as soon as they know I'm a consultant, they put the brakes on, because number one, they don't want me knowing all their different plans between offices. But 5 Lakes is my go-to company. They will credential you, they will negotiate your fees, they will contract you with these plans. And they are the experts about taking you in network, either directly or indirectly. I work with some of the most successful orthodontists in the country right now. And I can tell you that there is one that has participation with 98 plans, 98 plans. And this particular doctor contracted. She went through 5 Lakes, okay? They did all her negotiating, they did all her contracting. She has some of the highest fees that I've seen in the area. The other thing is, excuse me, there isn't anyone who walks into her office where she doesn't work with their insurance, which is a plus. So I encourage you that if this is something that you're thinking about, or you need to renegotiate or whatever, look to a company like 5 Lakes. I can't say anything any better than they're the best at what they do, in my opinion, and I've seen it from the ortho side. I've also seen other companies where they negotiate, but remember, these companies come from the dental background, first of all. So they're looking at maybe, 50, 100, 200 codes that they negotiate. And not all of them are great at bringing it together with the orthodontic codes. So tell them I sent you if you look into 5 Lakes and consider their services. If it's something, it will be worth every dollar that you invest for them to work with you. Something that is a big thing that we'll talk about in detail during our full day November seminar is the way you submit. When you work with carriers and you're in network, you've got to have a strategic approach to how you submit your claims. Bundled is a word that's been in our industry for a while. If you go back many years, we used to have a charge for our records. We have a charge for our treatment. Sometimes there were retainer charges, okay? To make it easy for patients to accept our treatment, we bundled our fee, okay? So we bring them in, we give them one fee, we give them a payment plan. It reduces the obstacles in terms of patients accepting your treatment. What has happened is that mindset of bundling has become the method that we submit our insurance claims to. Now, if you're out of network, not a big deal, okay? But if you're in network, it's a very big deal, because with every code, you have a dollar allowance. So if I submit a claim like this for 8080 and I have insurance that's only allowing me $4,700, I've just taken a hit of $1,100 on a discount, on an in-network discount on this particular plan. So what you need to do if you're in network is you need to make sure that in your office, you're unbundling your submissions. And probably the best clarification is to give you a shot of OrthoFi. And OrthoFi is going to look at everything that you do within that treatment, everything that's billable. And the patient, it's not a situation where anything changes for the patient. It's a situation where you're reducing your discounts because you're picking up more codes in terms of what they allow. So the office that I mentioned a little bit ago in terms of the 98 plans, 98 in-network plans, when I began working with this practice a few years ago, we went in and we did a strategy in terms of how they were submitting their claims. And we looked into their treatment and we unbundled things. And it made a difference. I believe after a year or so, they said that their average fee increased by almost 25% as a result of that, which is significant. So unbundling is something that you really need to be doing if you're in network. Strategic submission is the unbundling process. It's going to be your diagnostic codes. It's going to be your appliances. There are times when an office or a doctor will have types of treatment where there may be additional appliances that are billable. And I don't put that out there lightly in terms of everyone can do it. I would only recommend it to an office that I familiarize myself with and talked through treatment modalities with the doctor. You realize that many times we're doing cosmetic billable procedures when we do treatment, all right? IPR is totally billable. If we do what's called an enamelplasty, where we contour incisal edges to make for a more aesthetic look, those are all billable codes. So if you're in network, you have to realize that you could be missing so many dollars on a case and maybe hundreds of thousands of dollars in your office because you are not unbundling your treatment when you send it in network. Again, if you're out of network, not an issue. But if you're in network, you have to look at those particular situations. Also, you could have patient out-of-pocket situations. Not every carrier will do this, but there are things cosmetically, lingual treatment. Invisalign, yes and no, depends on the carrier. But there are certain types of things that you do that you are well within your right to charge that patient out of pocket for it. If I can say this about the cosmetic procedures that I just mentioned, if you look to do an unbundling of your treatment and you have cosmetic procedures, you have to make sure that you're documenting as such. So in other words, I'm not just going to do an adjustment. I'm going to do an adjustment with interproximal reduction, and I'm going to make sure that I document that so that it's on my treatment chart. That's the point that I can bill that with a date of service. Same thing with an enamelplasty. Let's make sure that we're doing it. I usually recommend to my doctors that we do a D-band with enamelplasty. That way we know we can pick it up in terms of having to be submitted to the insurance. So it's not just a matter of opening up your claim and putting all kinds of codes in. You've got to manage this within your process where you are not committing insurance fraud and you've got all the documentation that needs to go with it. So that's strategic submission. You're unbundling the types of procedures that you have, which increases your allowance and decreases your discounts. I've had numerous staff members over the years say to me, well, that means the patient has more out of pocket. It does mean the patient has more out of pocket. But remember, we're looking out for the practice in terms of we don't want to be discounting anything more than we have to. Interesting enough, I've gone into offices and one of the first things I do is a little bit of an analysis of their charges, receipts, and their adjustments. And it is not uncommon for me to see adjustments that are between an average across the board of 10 to 15%. I recently began working with an office where they had gross charges. Their adjustments totaled 18% before they came to their bottom line. Now, when you do that, that means 18% across the board. Every fee that walks into your office, you're discounting an average of 18%. Some are more, some are less, but that's significant. And I can tell you that offices that are in network, that are strategic in terms of the way they submit and they look at their treatment, will not be anywhere near that kind of discounting. So it takes some work to put the plan together, but it's certainly well worth it in the end. Here's a case in point of an office that I worked with a number of years ago. And we went in, maximized the submission in terms of all billable codes. We tracked it by a certain status that we gave the treatment so that we knew exactly how many of those types of treatment were coming through the office. We went back into 1 year after we finished the calendar year, and we pulled up all those charges, and we looked at what it was before we began strategically submitting and what it was after in terms of our savings and discounts. And this is what it came to: over $250,000 in a year. So that's how much that doctor was discounting from one plan in terms of certain situations. And that's how much more they were able to add to their bottom line when it came to strategically billing their insurance. So if you're looking, I always say, don't be penny wise and dollar stupid. Services like 5 Lakes Pro, any service that's out there that can give you an advantage in terms of increasing your bottom line is certainly well worth it and will pay for itself in no time. I am going to refer to some things throughout this program as cause and effect, okay? Just to give you a little idea, cause and effect is a philosophy that's used in science a lot, but I also see it in business. And basically what it is, it's an action that you do or an action that you don't do that results in a certain situation. And that happens very frequently with insurance. So let's look at a couple cause and effects that I'm going to bring to your attention throughout the webinar here. One of them has to do with carriers and some of the things that they're doing internally. And this is a situation with out-of-network providers. So if you look at the left side of the screen, we're talking about your treatment fees, $5,800. A patient comes to you and they have a benefit that pays at 50% of the fee, and they have a maximum of $2,500. So you're non-contracted, you're out of network, you estimate that benefit to be $2,500. Well, carriers are basically putting into place situations where their UCR prevails. And when I refer to UCR, it's a term that has to do with being with in-network insurance. It's usual, customary, and reasonable. It's like you set your treatment fees in the office and carriers set what they refer to as their UCR, their fees. So what's happening here is carriers are reverting to their own allowance of $3,800. So you take this situation right here. You brought a patient in at $5,800. You calculated their benefit against your fee because you're out of network. But now you find that actually it's only $3,800 that the carrier will calculate that benefit against, and it comes up to a benefit of a patient for $1,900. $600 you have overestimated that benefit. And cause and effect. I see a lot of offices where they have an underpay, and you come to the end of it. You don't realize it till you're at the end of it. And what happens is you work your way backwards and you find out that this was a situation where the carrier UCR prevailed in terms of your fee. So this is something that's happening, something that you have to look for. I mentioned that we were going to talk about GIHA again. All right, I'm going to spit it out right now. GIHA is notorious for this. But step back into that strategic contracting and go through GIHA indirectly with a discount plan. And it's a win-win for everyone. So you really have to know how carriers work, how contracting can make a difference indirectly or directly, and how it affects your bottom line. Those are all situations where patients are very unhappy because now you don't want to eat $600 in terms of making a mistake. And in their mind, they say, if I'd have gone in network with an office, I wouldn't have had this situation. So a lot of offices are finding this. And if I can just say one more thing, when you have situations like this, plans are putting options out there for subscribers to take on a plan. And it might say you have $5,000 in orthodontic benefits. But what's happening is that $5,000, they'll never realize that. Maybe if they have several courses of treatment and they stay under that plan, but they'll never realize it because their carrier is using a UCR where the benefit will never be more than $1,900 that's paid. And everyone knows those patients walk through our doors thinking, I have little or no out of pocket because of my insurance benefits. So that's a lot of information to digest, but it's very important. It's important to understand if you're an insurance coordinator, certainly if you're a doctor. CDT codes will be updated every year. And what you're looking at right now, if you don't have it in your office, insurance coordinators, you need to go to the AAO website and you need to search CDT codes and you can download it. So make sure that you have your CDT codes. It's not uncommon for me to go into an office and they don't have fee schedules, they don't have CDT codes. This is important for you to have, and I'm going to tell you why. Because in 2022, there are changes coming. The AAO lobbied the ADA to drop interceptive orthodontic codes. I always say they know not what they did. Because if you're in network, you know that those interceptive codes gave you wiggle room. They basically were like a mid-level allowance. And I'll show you what I mean by that. What I mean by that is if I look at an orthodontic fee schedule, I have my limited codes, my interceptive codes, and my comprehensive. Now look at the allowance on the right-hand side. So if I'm an in-network doctor and I was submitting interceptive or phase 1 treatment on an 8060 code, I had an allowance of $2,900. Now those codes, 8050 and 8060, are going to go away in 2020. And what's going to happen is I've either got to step back into a limited code, or I have to see if the carrier is going to allow me to code that as an 8070, which some of them do. You can see that right now I'm at almost half of the allowance that I was when I had an interceptive code. I can honestly tell you, have no idea how the carriers are going to look at this yet. Hasn't been anything released on it. But if you're in network, you need to revisit your fee allowances and you need to look at what you might have been submitting for phase 1 as an 8060 and what it is that your allowance might now be as an 8030. One other thing about limited codes, there are carriers out there that will not pay for what they determine to be limited treatment. So again, we've made this move, but we have no idea how the carriers are going to make this move. So I'm going to move past that and move into one other thing. Most doctors or staff don't know about non-covered services, but every state has legislation for insurances. And there is a rule called non-covered services, whereas if you have a patient you're treating and their insurance doesn't cover that code, you are well within your rights to charge your fee. And it does happen. So look to see if you're a state that's a non-covered services state, and you may be giving away more discounts than you really have to be giving for non-covered services. Now, when I say to non-covered services, if you have an adult come in who doesn't have orthodontic coverage, it's a non-covered service. So am I discounting that adult treatment when they don't have orthodontic treatment? And I'm well within my right not having to do so. So that's one other thing that I want you to know about carriers. A lot of information, but you have to realize that it starts at the top. And those are some of the things that are being put into place with carriers, have been in place, put into place, some of the things our industry has done in terms of changing codes, and they're going to impact you. So again, look at what it is you have. Make sure you have updated fee schedules. Make sure you know how it is you're submitting things if you're in network, and how it is you might need to change those things going forward in 2022 And if you're out of network, considering should I be in network, look into a service that will help you contract indirectly. It will make a world of difference. Okay, so let's step down from carriers now and let's look at benefit plans. So there's three kinds of plans out there, and I'm going to tell you why. I'm going to explain that to you in a little bit. There's a commercially funded plan. That's basically where an employer will contract with a company like MetLife, and they pay MetLife, and MetLife will pay the premiums. Then you have federally funded and self-funded plans, okay? The self-funded basically means that your employer has hired a carrier, maybe as a third-party administrator, but everything that's being paid on the insurance is coming out of the employer's plans. Now, why do I take the time to say this? Because federally funded plans and self-funded plans do not have to be dictated by state insurance rules. And that comes into play with coordination of benefits. So I'm telling you that on the dental side of it, they're beginning to have to ask when they verify benefits, is this a self-funded plan? Okay, federally funded is a government plan, any kind of a government plan. Is it self-funded or is it commercially funded? If it's self-funded, that can make a difference in terms of coordination of benefits. Again, a couple hours isn't a whole lot to really dive deep into some of these things, but come on out in November and we can talk about everything that you have to look at there. So the other thing I want to explain to you is the structure, the models that insurance will pay dental. First of all, there's 4 classes or 4 levels of services that they look at. Preventive, basic, and major are all dental insurance. They're usually paid under a model that's 100% for preventive, 80% for basic, and 50% for major. Then you have a class 4 dental benefit, which is orthodontics. Not every dental plan will have orthodontics, but that is paid at 50% and above. Sometimes it depends. So remember this benefit structure model, and I'm going to tell you why I'm bringing it up right now. Why I'm bringing it up is because now there's a code crossover, okay? An example would be under preventive, you have space maintainers that can be paid. So many offices over the years, if they've done space maintainers or lower lingual holding arches or TPAs, they've submitted this under dental. They have frequencies in terms of like what they'll pay. And now you can have crossover, okay? Orthodontics, if you drop down to the orthodontics section where it says 8660, strategically, offices have used that over the years as like a pre-treatment type benefit for the diagnostic part because it might allow up to $500 or more. And now what's happening is the benefit plans are using the orthodontic exam codes and they're lumping them in with the preventive care exam codes. In other words, you can go to the dentist and have 2 exams a year. But now, if I go to the orthodontist and my orthodontist submits that 8660, they're going to take away one of my exam codes on the dental side of it. So it's code crossover. These are things that are happening within plans. You have to look at how it may impact your office, how you treat, what kind of appliances, what kind of a trend if we had for submission, because you usually find this when you're left with a balance on an insurance ledger. The other thing that a lot of doctors don't realize is that if you have any kind of extractions, deciduous serial extractions with growth and development, or a bi extraction, with full treatment, when you send that patient for extractions, it used to be that it was hit or miss, but those extractions could have cost $800, and because it was for orthodontics, they take it from the ortho benefit. So that could be either under a basic or a major service, but carriers are looking at more code crossover in terms of where they pull the benefits from. Are they pulling it from the dental side, or are they pulling it from the ortho side? And you have to look. Again, when we verify benefits, some of these things may be questions that we're going to have to ask. But it's something that you should know in terms of the structure of benefit payment models and how it may affect you. These are the codes that will typically cross over if you're using an 8660, okay? That DO150. I've seen offices who will use that DO150 as their treatment planning code. You know, you do a complimentary evaluation, but then you do maybe diagnostics and a treatment plan. And there are still offices out there that are doing formal consultations after records. That 0150, if it's used in your office, is going to take away from the dental code that they have twice a year. So 8660 or 150 is going to take away their dental codes, which doesn't make the general practitioner very happy. That's really how it came across the first time that we started realizing that a few years ago in one of my offices. Dental deductibles are something else that's changing rapidly in terms of the orthodontic side of benefits. On the dental side, patients were used to deductibles. It was typically annual. It was a menial amount in terms of $50 or $100. It was seldom applied to orthodontics. And if it did apply, it was mostly, it affected maybe a lower fee, like phase 1 or less than 12 months. So it didn't play a whole lot into the orthodontic side of treatment. Now you have orthodontic specific deductibles, and they can be annual or they can be one time. The other thing is they're fairly significant in terms of the dollar amount. And I'm going to give you an example. Had an office that I worked with where a patient came in, presented with an ortho benefit that had an annual deductible of $250, okay? So this meant that if that patient went into a 24-month treatment, 2 calendar years, they were going to take $250 of my ortho benefit every year, which meant in 24 months, that patient has just lost $500 of their ortho benefit in deductibles. If that 24-month treatment fell over the course of 3 calendar years, that deductible was applied 3 times. So these are all the things that are coming into play that you're going to have to ask about. Okay, verification is going to become more and more important when it comes to all these exclusions and limitations and things that are happening within benefit plans. Transition of care. Insurance coordinators are going to relate to that as work in progress, and we know that we get a lot of them. But what happened a few years ago is there started to be a rule or an exclusion that was referred to as transition of care. And let me explain to you what that is. In my day and age, if I had a person that came in with a benefit of $1,200 and their employer changed their plan a year or so later, and they got another $1,500, that accumulated, that totaled. Transition of care means that when a patient appears in your office and you begin treatment and their benefit is $1,500, okay? The plan that would take over is now truly looking at a lifetime maximum. What's going to happen is they have a transition of care clause. You're not going to get the new $1,500 benefit. It's going to revert to the limit of the maximum of the original benefit. So what happens is the first insurance paid $1,500. By the time they transitioned into a new plan, they had paid $1,200. The new plan has a transition of care clause, and they're only going to pay $300. Okay? So again, we were finding these things as a result of underpayments. So you have to assume that this is going to be the case when it comes to benefit plans and work in progress cases. I'm going to give you a quick screenshot in terms of a work in progress claim. You get a lot of them that happen within the office because most benefit plans are not contracted for more than a couple years. So take a screenshot. This is an example of how I submit a work in progress claim in my office. The original information would be at the top. I put the dates that the new benefit is now covering. I revert back to the method and the breakdown of the payment, and I ask them to prorate it for the dates that the new insurance is effective. FYI, these kind of claims submit manually within the mail. I even have a cover letter sometimes that I will send with a work in progress claim. If you submit them electronically, chances are it's going to get lost in the clearinghouse. They're not going to pick up all the information that they need. So these are work in progress claims. Look at my example, visit your carriers. Many of them now have examples of how they want it submitted on their websites, but we get a lot of them because patients frequently change insurance. All right, let's visit another cause and effect when it comes to benefit plans. Governing treatment time. And I referred to the word governing because that's what's happening. Plans are basically setting time limits or time frames on what you can bill or what they can pay. Cigna was notorious. Phase 1 had to be 12 months, okay? If you submitted for less, chances were they were just going to cut the benefit in 8 months. They didn't necessarily calculate the benefit against those 8 months. They might have calculated against the 12 months, but stopped paying at 8 months. Full treatment, if you submitted it for 18 months, same thing was going to be happening. They were going to stretch out their payment by 24 months. Cigna was notorious, okay? Other carriers are starting to follow suit. So another thing that you have to look at when you're verifying benefits, and you look at what happens when that patient loses a benefit, you know, before they finish treatment. It's become a struggle in many of the offices that I work with, where I see these kind of situations happening. And it's a crime as far as I'm concerned. I really believe that there needs to be some advocacy on the dental side, on the ortho side, when it comes to the things that carriers are doing. And the other thing is disclosure. If you have a situation where a patient has this, ask them to bring their benefit information in detail to the office, because these are the kind of things that should be disclosed, not just that dollar amount when that patient is signing on for a benefit plan. So governing treatment time is something else that you're seeing benefit plans do. Let's talk about coordination of benefits a little bit. I'm surprised sometimes at the offices that maybe I've worked with for a period of time and find an insurance coordinator that says to me, I never knew what a maintenance of benefit was. It's always been there, the methods that they coordinate benefits with, but I believe they're starting to utilize more of them because it saves the carrier money. It's more profitable for them. So most offices will look for the rule to determine who's the primary carrier when you have a coordination of benefits. Could be the birthday rule if you have a mother and a father. If you have a divorce situation, very often it could be custodial, or we know that it could be a court order that overrides everything. But this is typically what most offices, this is their go-to when they have more than one insurance. What you have to understand is that there are two factors for coordination of benefits. You've got the rule to determine who's primary, but then you have the method that the secondary coordinates with. And let me show you what it is, okay? I refer to it as there's no coordination, there is coordination, or they have a non-duplication of benefits. So it can be referred to the no coordination as traditional or standard. The other level of coordination, which is maintenance of benefits, could be referred to as MOB or a carve out. And then non-duplication is pretty much in your face, non-duplication of benefits. So let's look at how that breaks down. Remember, this is the method that your secondary insurance is going to use to calculate how much of a benefit they will pay on your treatment. Cause and effect. The majority of offices, I'm going to go back, will assume that a secondary is traditional. They've determined that we know who the primary is. We're going to take both dollar amounts and we're going to assume that it's traditional, or they don't ask, they don't look for it. So cause and effect, you are left with an underpayment on a secondary insurance because you didn't look for that method of how the secondary would calculate benefit. So let me give you a couple examples. And this is a traditional, okay? You have a treatment fee that's $6,000, primary $2,500, secondary $1,500. You're gonna have the primary that's gonna pay $2,500, the secondary steps in. They really don't care what the primary paid. They're going to go to that $6,000 fee and they're gonna calculate it as they would if they were the only one. So that's traditional, standard. I refer to it as there's really no coordination. Another example would be a treatment fee at $2,500, but excuse me, a treatment fee at $4,000, but a benefit at $2,500. And this is a simple calculation, but again, a lot of misunderstanding in offices. A patient will come to you with a benefit and they know they have $2,500, but that percentage is that's first and foremost. So if a treatment fee is $4,000, what is the percentage? The percentage is 50% up to $2,500. So that estimated benefit is $2,000. Same thing on the other side for a secondary. If it's traditional with no coordination, I have got $2,000. This particular patient, very lucky, they had no out-of-pocket whatsoever with their coordination of benefits. Now let's step into what I call a maintenance of benefits, okay? A carve out, a maintenance of benefits. Dumb it down, they coordinate, okay? They care what the primary pays. So here's how they work. I have a treatment fee of $6,000. My primary has a benefit that pays at 50% up to $1,500. So I've got $1,500 for my primary benefit. My secondary steps in. The first thing they're gonna do is they're gonna subtract that primary payment from the treatment fee. And they're gonna come up with a new bottom line, which is $4,500. They've carved out what the primary pays, okay? They're maintaining the bottom line in terms of their benefit. The secondary steps in, $2,250 is 50% of $4,500, and that's what they pay. Here's another example. I've got a little bit larger benefits. Now, you know, this patient is gonna walk into your office, they're gonna say, I got $2,500 with my first one, I got $3,500 with my second. I've got $6,000 in benefits, but their plan has a coordination for a maintenance of benefits. So what happens is, first plan steps in, you've got $2,500. Secondary plan takes that same thing. They subtract that $2,500, they come up with a balance of $3,500, and that's what they're gonna pay their benefit against. So $1,750. So this patient who thought they'd have no out-of-pocket whatsoever does have out-of-pocket. And unfortunately, we're the educators for these type of things. They are not disclosed when it comes to plans releasing this kind of information. You really have to dive deep when it comes to verification of benefits. Now let's talk about a non-duplication, because these are really the things that parents are very upset with. And again, we're the bearer of bad news. Remember I said how state regulations apply to plans? State regulations, they are in charge of coordination of benefits. So if you have self-funded plans or government plans, they don't necessarily have to follow that coordination of benefits. Hopefully we don't even have to go there for a while, but you have to be aware of it, because sometimes you're like, well, we didn't think we were gonna get that money. Why did we get that money? Hey, maybe it was a self-funded plan and the coordination of benefits it wasn't significant. So let's look at how non-duplication is. Treatment fee $6,000, primary has a $2,000 paid at 50%. They get their $2,000 with primary. Secondary has $2,500, patient's perception, $4,500 in benefit. Now, what's gonna happen is the secondary will pay up to $2,500, but they're not going to duplicate a dollar amount paid by a primary. So what happens is they step in and they'll pay the difference. Primary already paid $2,000. Your benefit with me as your secondary is $500. That's what you're going to get. Parents are livid when they understand these are the situations. And very often they sign up for these plans thinking they're going to have that dollar amount to put towards their insurance. So that's a non-duplication. Let's look at another one. $3,000 with the first, secondary is $3,000, they get nothing. So you have a parent who's coming in who may be paying for a secondary premium, but will get no orthodontic benefit from it whatsoever. I caution my offices because many times your patients, they trust you, they believe in you, they think you're a source of information when it comes to insurance, and you don't want to not know these kind of things. But when your patients may come to you towards the end of the year and they may say, I'm going to bring the choices I have for benefit plans in, and can you help me decide what it is I should get? Don't tell them. Tell them what to look for, okay? So in other words, let them know, look for coordination of benefit rules, look for waiting periods, okay? Look for the things that you know are limiting benefits for your patients. So don't tell them what to do, tell them what to look for. Let's step in now to what is assignment of benefit. For those doctors who might be with us, this is a big misperception, okay? When you have assignment of benefit in your office, it doesn't mean that you're contracted with a plan. It means that you agree to let that patient's benefit come to you. So again, over the years I've gone into offices and I've had to very clearly ask, are you contracted? Do you take assignment of benefit? Okay, they think when they take assignment that it means they're contracted. Assignment of benefit will come to you instead of the subscriber. So I gotta jump in here and tell you something and give you an example with OrthoFi. We are in a mentality of same-day starts in our office. And that verification is important. You know, it's doctors, it's like your treatment. If your treatment's going to go off course, if it's going to take longer than you anticipate, it's going to happen at the front. It's going to happen within the first so many months. It's not going to happen at the end of your treatment. Same thing with insurance or other processes. They fall apart at the front of the process. And same day starts, you can't afford not to have your verification correct, okay? The other thing is, OrthoFi is a wealth of information when it comes to statistics, okay? Something that I couldn't really put together in the offices that I work with. But if you look at where a treatment coordinator makes that welcome call, I always coach my TCs to say, your welcome call isn't a confirmation call. It's an introduction. It's telling them, hey, we're prepared for you. We've looked at your insurance benefits. You have a great benefit. You have $1,500 that we feel you'll get in full that will reduce your out-of-pocket. How important is that? Well, OrthoFi looked at what they refer to as total recommended conversion, okay? Case acceptance. There's several terms used out there. With the app that will inform the patient after verification in their process, they've noticed that there is a difference in same-day starts, okay? Patients who've had the push of that insurance benefit information have a higher conversion of 72% versus, if they don't know about their coverage, 58. A statistic that I've never looked at, I'll be honest with you, I've always thought that welcome call was important, but I didn't think that it had that big of an impact when it came to our conversion. Only that they were all positives and we were prepared for them. So again, kudos to OrthoFi for looking at just how important these kind of things are. So don't forget, if you're doing same day starts, you've got to have your ducks in a row when it comes to your verification of benefits. A deep dive. I use this information and OrthoFi uses that phrase in terms of a deep dive into your eligibility or your verification of benefits. The majority of offices will ask several things. What's the dollar amount? What do they pay at? Is there an age limit on adults? Have they used anything? Okay. All of the things that I just talked about with carriers and plans, you've got to look at. You've got to dive much deeper into that verification. And if you're doing it on your own in your office, you know that right now, COVID and post-COVID, it's become a nightmare. So let me give you a few tips about your verification of benefits. And again, look at what's a trend. Are you having underpayment for your insurance? If you are, back your process up, look at your verification, see if that needs to be stepped up a little bit. The eligibility check with OrthoFi, they're going to summarize all these things in terms of what it is that you need to look for, and they're going to call these exclusions and limitations to your attention. Carrier documentation. If you're verifying your own benefits, I always like to take whatever it is I can get off the website or via fax, and I like to make that a document of record. Why? Because if you're only making a note on a notepad that says 50%, $1,500 pays adult treatment, okay? When there's an underpay, inevitably, it's your fault. You didn't find it. But if I have what a carrier will make available to me, it basically supports the fact that, hey, this is the information that they're releasing, okay? So I always say, whether it's 100% of what you need or whether it's just touching the surface, store your carrier documentation for the insurance benefit plan in your system. Let's talk exclusions and limitations. Age has always been a thing we've looked at, typically over 19. Now the dependent age was raised to 26. That's typically the number that you get if there's a limit on age. Benefits will cease. If you have a patient who ages out, you know, they start treatment when they're 25, they turn 26, their benefit stops, okay? Now you're starting to see benefit plans that are saying a minimum age of 8 for orthodontics. So if I have a patient who's 7, 7.5, they need a space maintainer, or they're dentally, you know, they're advanced when it comes to their dental growth. You might have to look to see if there is a minimum age for orthodontists, because many plans are putting it in place. And just an FYI, if you're doing space maintainers and you're pulling it out of the dental side of benefits, they have a range. 8 to 14 is typically where they put the patient base that can have space maintainers under a dental plan. So these exclusions, limitations, and rules, figure out what it is that I'm asking. Is it giving me everything that I need? Code use, single comprehensive code. Step back to where I said in 2022, there's going to be some changes that are coming with codes, okay? If I can't use an 80/70, which gives me more of an allowance for my phase 1, I have no choice but to go back, step back, and go to limited codes. It's not uncommon that there are carriers out there that won't pay for limited treatment. So make sure if you're in network, you're visiting your fee schedules. If a benefit's calculated against a UCR, I guess that was cut off a little bit. If it's medically necessary, if it's waiting periods, and the eligibility date. Just an FYI, we drove ourselves nuts in one of my offices a few years ago, understanding why a patient wasn't eligible for their ortho benefit. When we verified the benefit, we saw it was a waiting period, and we waited out that period of time. Well, what had happened after we really dug and dug was that the patient didn't go on the plan at the time the plan became eligible. So basically what you had a waiting period for the plan, but when the patient went on the plan, they had their own waiting period. So now in my offices, I always say, hey, look for your waiting period, look for your eligibility date, and make sure that the patient falls under that eligibility date. Okay, whoops, let's go forward here. Medically necessary. Everybody's pretty familiar with this since Obamacare came about a number of years ago and the 10 essential health benefits. But let me tell you the flags that I'm seeing in terms of the clauses and the verbiage that they're using in plans to indicate it's medically necessary. Look for these 3 things. Pre-authorization is necessary. There's no maximum allowance. And the latest one is a clause that says orthodontic benefit under pediatric dental, okay? that's medically necessary treatment. So don't miss those flags when it comes to finding the type of benefit that that patient is presenting you with. And I maybe should have thrown this a little bit earlier into the presentation, but same day starts. Again, let's look at having all your benefits in place, same day starts, what really is a national average when it comes to gauge, okay? They're basically at an average of 19.4, and OrthoFi is an average of almost 43% when it comes same day starts. So look, you know, doctors, look at what your objectives are in your practice in terms of growth, in terms of efficiency. Same day starts have so many advantages. Where I live in the Baltimore, Washington area, if you don't have that start, they're going to go get another opinion or another opinion. So have all the tools in place, have your staff familiar with all the things that are going to position us for our same day starts. Fee transparency is something that I want to talk to you very quickly about. Again, common for me to go into an office, and in-network doctors only provide the bottom line fee to a patient. I'll give you an example. Excuse me. Your fee is $6,500. Patient has MetLife. You're allowed $4,700. It's actually $4,950 for most offices. So you give them a treatment fee of $4,500. Okay. First of all, give them fee transparency. Give them your fee. Let them know what their benefit is in terms of their in-network plan. Okay. I refer to it as your first insurance benefit is a fee reduction. Okay. Because we participate. You refer to that as a benefit. Okay. Let them know, because mom who just brought you kid number one, you're giving her $4,500 or $4,700, and mom thinks your fee is $4,700. When she presents with child number two, and she's not under that plan anymore, now you're presenting her with your $6,000 fee. Hey, it's been a year. Why is it a $1,500 difference? Because you didn't have fee transparency. Excuse me. The other thing I'm going to tell you is that the offices I work with have been extremely successful in not having to do additional discounts because they're presenting exactly what it is the patient has off for their in-network benefit. So make sure that you have fee transparency and that you're not just laying out that bottom line for in-network patients. Do you have signature on file? Years ago, we used to have little stickers that we'd put on the claim forms. Well, we're in the digital world. When things became digital and no longer material, we had to have signature on file. Most offices will send their claims in and they'll mark all their claims signature on file. All right. You'll see on the claim form where you require 2 signatures there. You tell them you have it on file. Do you have it on file? Most of the offices I go into do not have it on file. Okay. If ever you have a payment that goes to a subscriber that should have come to you, they're going to ask you, could you show me your signature on file? So what I like to do is don't create extra paperwork. Don't create another form. Just take your financial contract, go to the bottom, put the signature in there where underneath the contract signature, you also have those 2 signatures that are required on your insurance form. And I'm going to read you the benefit, or excuse me, read you the verbiage that I put in that contract. And this will kind of come to light a little bit later. My verbiage says, I will do everything necessary to assist the office of Dr. Byrne in receiving the credited insurance benefits, if any, okay? I am aware that my insurance is responsible. In addition, this will serve as my submission of all insurance claims and assignment of benefit named to the office. The other thing I do is the little clause about insurance becomes their obligation. The unpaid amount will be charged back to your account and becomes due immediately unless other arrangements are made with our office. when I go through managing your insurance receivables, I'll explain why I'm very specific about that. So make sure your paperwork is in order for your assignment of benefits. Let's go to our last category, insurance receivables, okay? Most offices should and do have a pretty regimented system for patient receivables, okay? In other words, when that patient becomes delinquent, at a minimum, they do a statement, they do a letter at 30 days, 60 days, 90 days, okay? It's regimented. Most offices have nothing in place for their insurance receivables, okay? Let's go through a couple things. These are a few rules that I have when it comes to your benefit payments. Insurance gets posted on an insurance ledger, okay? And that there's a ledger for each insurance. So if I have a patient and they have insurance, I don't want to be posting patient payments on that ledger and insurance payments on that ledger. I want a ledger for the patient and a ledger for insurance. If they get a second insurance, I don't want to mix two carriers on that ledger. I want a second ledger for that second insurance. And this is a biggie. When you put the description of your insurance in there, put the date of service. When you're chasing down unpaid benefits, you're going to revert back to EOBs and you're going to look for that date of service. And if it's on your ledger, it's all in one place. It's chronologically sorted for you. So make sure that at the time you post payment, you put the date of service for your payment. Cause and effect. I always say to doctors or, practice managers or insurance coordinators, posting your benefit payments is not a mindless job. In fact, I would say 50% of overdue insurance are a result of the person who posted that payment missing codes or notes that were on the EOB. If you do have other team members posting your insurance payments, at least make sure that they're putting your EOBs together and you as the expert insurance person has a chance to review those EOBs. Here's an example of where maximum was paid, they're not going to receive any more insurance. They're all over the place. They can be anywhere, okay? You have to search those EOBs. No coverage in effect, okay? So, couple rules when it comes to your receivables. When the benefit is more than what you thought it was going to be, okay? Allocate it at the time that you're posting payment or reallocate it. What I mean by that is, if you just got more insurance than you thought you were going to get, take the portion that's overpaid from the patient and put it onto the insurance. Then adjust your auto receipts. And that's what happens. Doctors hate nothing more than writing refund checks to patients because they paid more than they had to pay, okay? And many times, almost all the time, it comes because a benefit payment paid more and we didn't reallocate and we didn't adjust our auto receipts. So that's a rule. Going backwards, we're going to go forward. What do you happen when the benefit is less? Okay. Transfer the balance as one payment and mail the patient an explanation and a statement. Okay. I'm going to show you an example of a letter. I've gone into offices and when I've audited insurance, I've seen a benefit that should have been paid, it's 6 or 9 months overdue. And the insurance coordinator says, oh, they have new coverage. They're giving us the information. And I'll look at it, I'll look at the notes and they talked to that patient 4 months ago. Okay. So when you identify that you're not going to get a balance on an insurance ledger, move it. Move it at the time that you find it. Okay. If you have a slow paying insurance, ask for assistance from your subscribers and your responsible parties. I explain it as such. We deal with provider services and you deal with subscriber services. You're entitled to a prompt payment and prompt resolution. We don't have that luxury. I really need your help. Going back to that contract clause, it says it right in my insurance clause. So when the benefit's less, look into it, handle it immediately, and ask for help when you need it. This will get things done quickly for you. When I move that benefit over to the patient, I send them a letter. Your insurance indicated they're not going to pay anymore. Here's your balance. We pre-credited this at the start. This is your responsibility now. And if you don't make that payment in the next 30, if you don't contact me, I'll assume you're just going to make that payment in the next 30 days, okay? But get it off that insurance ledger, because if you don't have a good system of follow-up, you're going to end up eating that underpayment. All right, policy changes. Benefit plan changes, okay? These are office policies that I want to tell you need to have in place, because they're rarely in place. What happens when you have a benefit change? When you have a new benefit that replaces an existing benefit, whatever balance is left on that insurance ledger, just move that over to the new insurance, okay? Don't pre-credit new benefits. Remember transition of care, all the things that are in place when it comes to carriers and plans. You don't want to change that patient's payment plan. I always say, I'd rather give you back than to ask you for more. So that's a policy. Just move over whatever it is that's left on the insurance and assume that that's what you'll get. What happens when the new benefit and there's no previous benefit pre-credited? Many offices will verify, they'll change the patient payment plan, they'll go through all kinds of things, okay? I like to submit, worst case scenario, submit a pre-authorization, okay? They have to tell you what they're going to pay with a pre-authorization, but don't rush to make payment plan changes. Get things in place, do your submission. What happens when it's a new benefit in addition to the existing pre-credited benefit? Okay, that can be all over the board, because now your new benefit might be primary and there's a whole coordination of things. Stick with your original pre-credit amount, let the patient know this could take some time for the insurance plans to coordinate amongst themselves, and we will take care of changing your payment plan when we get all the information. So don't rush to these things. Those are office policies that I like to have when you're managing your receivables. Let's talk about 30, 60, and 90 days with insurance. And here's the first thing I'm going to tell you. It's probably wrong in terms of the way it's aged in 80 to 90% of offices that I go into. First of all, if you have an insurance ledger and it says they're paid ahead, you're not aging that insurance ledger right, because nobody pays ahead, okay? So there is a rhythm that you have to get to it, but make sure that if you're managing your insurance aging, that you have a correct report to follow. I'm going to give you a few tips. Okay, this is an insurance coordinator's daily, weekly, monthly checklist when I work in an office, okay? These are the daily things, okay? They look at scheduled patients 2 days out, okay? And if there's any kind of an insurance problem, they head it off. Work in progress claims are submitted when they're provided to the office on a daily basis or within 24 hours. We're transferring benefits from an insurance ledger on a daily basis when we receive the payment and the notice. We're re-aging insurance benefits as we post insurance payments. Maybe not daily, but at least once a week. And there's task follow-up for any claims I've appealed or any promises I've had for payment or processing. So on a daily basis, you should be looking at those things. You probably do it for patients. Why aren't you doing it for insurance? The first of the month, submit your continuation claims. The first of the month, review insurance credit balances on ledgers and move them over to the patient or reallocate accordingly. And then at least once a month, take some kind of a report that gives you everything and audit it. And just make sure that you're catching anything where you haven't had a payment for a year and a half or anything that's falling through the cracks. But if you do this weekly thing that I'm going to give you next, you probably won't have things fall through the cracks. Here's a checklist, 3 things that my insurance coordinators need to do every week at the start of the week. They're going to review the previous week's starts and they're going to make sure that anybody with a benefit, it went out, the claim went out. Sometimes we find it because it's 90 days old and the claim never went out. But if every week you're looking at the previous week's starts, you're never going to miss a claim. We look at the starts that were 4 weeks ago. Why do I do that? I do that because by 4 weeks, I should have my initial payment, okay? If I don't have my initial payment, call the carrier, okay? Sometimes you can go online, you can look at their benefit. If they've used some of it, you know it's been paid. Resubmit and request help if you need it. And then once a week, pull up your claims that say they're 30 days and make sure you're on top of it. So that's a weekly rotation that I give my offices. Every week, do that. You're not going to have claims that fall through the cracks that way. Again, I would say that these statistics, according to Gage, are not accurate because I don't see offices aging their insurance properly. With the average with Gage, you're at over 2% in terms of your delinquent dollars. OrthoFi, the system and the technology is managing it for you. Their offices average under 1% of their insurance receivables being delinquent. So here's something else I would say to you. Insurance can be predictable. You know, when the year change is over, we have this mass rush of patients who come to us with new benefits. In my offices, my clients, we start sending out insurance reminders. September one goes out, October, November, January, February, okay? It reminds them that if they have a benefit change, they need to bring that information to us promptly. The other thing I see is observations, pre-treatment patients on our schedule who we know are ready for treatment. What happens is we have the team rushing around verifying benefits because they're ready for treatment and we didn't have all that. I set up auto reminders for all my scheduled observations a month ahead of time, that if they have new benefit information to please call ahead, and we're prepared for it, just like we are new patients. So those are things that are so unbelievably predictable, but yet offices we're not ahead of ourselves. We're not proactive to it. So those two things will make a big difference. When it comes to insurance, I always like this saying, and you know, consultants were like real goofy when it comes to like quotes and sayings. According to Abraham Lincoln, give me 6 hours to chop down a tree and I'll spend the first 4 sharpening the axe. Couldn't say it better for insurance benefits, okay? You've got to get your process and all the policies within your office and your job descriptions. You have to get those in place, okay? Because if you don't, you're going to have either a very inefficient process or a very ineffective process of your insurance receivables. So listen to Honest Abe there and sharpen your axe. If I can depart with one thing, I will say this. The only constant in life is change, and insurance is constant change. We need to educate you. We need to provide you with tools, processes, things that will assist you as we go through these problematic times of staff shortages and everything that we do. I don't think there's been much said about it, but I am very eager to release with OrthoFi and OrthoBank the new tool that we'll have for in-network in terms of maximizing your benefits, going back to that strategy. So there's my email. Feel free to email me any questions. Thank you so much for joining me today. I hope I've provided you with lots of helpful information, and come on out to Denver in November and we will rock a full day of anything that you need when it comes to your insurance process. So I'm passing it back to you, Brian.
Awesome. Thank you so much, Tina. So yeah, we have a ton of questions. So thank you everybody that's been submitting questions, and I'm just going to kind of start rattling some off. If we don't get to all of them, we will absolutely make sure to follow up with everybody and use that as a follow-up point. So we know there's a lot of questions out there. Some are kind of repetitive, but we've tried to answer some of them in the chat. But Tina, we'd love to get your thoughts on some of these. So one of them is from Jaron Simonson, who's one of our OrthoFi clients out at Webster Orthodontics. Thanks for signing on. But he says he's been seeing a bunch of dental riders on medical plans recently. And what would you suggest when dealing with these? as they seem to be very cumbersome and tricky to navigate in the for the patient's best interest?
I think what he's referring to is medically necessary benefits. If it's under a medical, if it's a dental rider on medical, it has to do with Obama's 10 essential health benefits, where you have to provide pediatric care, and one of those 10 happens to be orthodontic care. You know, some offices never see them. Some offices have them in clusters. When they rolled out for the first 2 years, it was only commercial plans that could put those riders on. Over the years, you've seen them not only be under medical plans, but now be under dental plans. Make sure you're identifying them. They're medically necessary. Many of my offices will do, a quick consultation of the patient. They'll take whatever information it is that they have to send, because you have to go through the process. But we tell patients at that same time that you don't qualify, okay? If I'm not meeting my Saltzman score or whatever it is that I need, we tell them straight out, here's the way it works. And we've been very successful in my office doing that. If you have a patient who wants to sit on it and wait, or if you know you have a cleft or some kind of a deformity that could possibly do, then you might want to wait for it. You can't do same day starts on those because they require pre-auth. So if that doesn't answer your question exactly, shoot me an email and I will elaborate on it.
Let's see here. This one is from Candace Wolf, who is another OrthoFi client at Coos and Silman Orthodontics. As right now, our office is out of network. Sometimes when a new patient calls, they specifically want to know if they are in network. If they're not, sometimes the patient might not want to schedule. So do you find that in-network benefits provide the same lifetime maximum as out-of-network? And then also, how would you recommend explaining the difference to a patient on the phone to get them to come in for a free consult, even though the practice is out of network?
Yeah. I always say, just tell me what you have. I'll teach you a way to sell it. Okay. Multiple questions in there. Do I see different lifetime maximums? Nope, not always. Sometimes I would say that if a patient is an out of network, they might have a high benefit, but then you have that situation where the carrier UCR prevails. What I like to say to my team that are taking new patient calls with the question is this: when a patient says, do you participate with MetLife? And I'm out of network. What I always like to say is lead with the positive. Don't tell them they can't, tell them they can. Let them know that we've got lots of MetLife patients. We operate as an out-of-network provider, and this is the honest truth. Plans change frequently. We provide a course of treatment over a period of time, and that sometimes can be limiting within network plans, and it can be detrimental to patients sometimes, and it's the truth. But we always let them know that, how it works. And here's another truth. I see in-network plans that have allowances that are more than what doctors are charging, okay? So if it's the case, you could have a phase 1 treatment that you're well underneath an in-network treatment fee, and your fee's lower. And that's something else I say is we're familiar with the in-network plans, and our fees, for the most part, don't exceed those. So I look for the positives. The worst thing you can do is have your team say, oh, we don't participate. Oh, we're out of network. Okay. Don't let them lead with a negative, lead with a positive.
This one is from Lauren Stevens at Petty and Dragstrom Orthodontics. She has a question around, is it worthwhile to unbundle your claim submission when the treatment fee is over, let's say, $5,000 and the insurance fee is 50%, like $2,500? Do you think it's still worth unbundling your claims?
No. Well, let me back up a minute. First of all, I'm assuming you're in network. If you're out of network, you don't have to unbundle your fees, okay? You might have a $5,000 fee and they might have $2,500, but the component you're missing is, if you're in network, what do they allow? What's the maximum they allow me? If they only allow you $4,500 for that $5,000, now you're taking a $5,000 discount, okay? So if you're in network, you should do your homework. Look at your office fees, look at your allowances, look at what it is you're discounting, and you have to look at them each individually. You can't take MetLife and say, oh, we need to do this. Every one of them is different across the board in terms of their allowances and how you should bill them out. So.
Yeah, I know, I think you mentioned earlier, but essentially with unbundling, it sounds like obviously, allow you to charge more for the case. So there's obviously some opportunities there that, there's not going to be anything left on the table, which I think is a really great point you made earlier. Let's see here. Even if this one's from Maria, I'm going to botch this last name, but Seki, I guess pronounce it, from Devon Orthodontics. So even if I unbundle, we only get the lifetime max. Is that correct?
Okay. You're talking about a lifetime max. You're talking about a benefit, okay? The patient is getting paid that benefit, okay? When you unbundle, you're looking at what you're allowed to charge, Maria, okay? Unbundling is really a strategy for you to not have to discount so much, okay? So make sure that you understand the difference between what you can charge and the benefit they pay, because it's a big difference, okay? So that's how I would address that. If you need more explanation, shoot me an email.
This one is from Rita Schwang, or I'm going to botch that one too, but I've heard from another consultant that for Invisalign cases, since treatment planning and lab fees are paid up front, we should submit banding date when we approve the case. What are your thoughts on this?
Okay. Insurance, if you get a crown on the dental side, you can't bill that insurance until the crown is placed. So you've done prep and temporaries and everything else, but it's not billable. The same applies to insurance. Until you put appliances in the mouth, you can't bill it. So what we do is we start the contract. Their initial payment is due when we scan or when we start the whole process, before ClinCheck, is approved, before all of that happens. But you can't submit their insurance until you give them their aligners or you put their attachments on. So with Invisalign or aligners, it's two different things, okay? You can start the treatment in your office financially and start the contract, but sit on that claim until the aligners go in and make sure that that's the date you use for the placement of their appliances. And what we do is we set the contract up, we put a note on the schedule for the day the patient's scheduled for their aligners, and we pull out that claim and send it that day.
This one is from Stacy Fletcher with Robley Orthodontics, one of our clients. How are you? What about the D0160 code? Can it be used for an ortho exam, and does it typically go against their allowed exam limits?
Again, that's the crossover. You can use that 160 code, which is the extended examination code. And yeah, absolutely, you can use it. I'm assuming you're in network, which is you're going to unbundle it. The only caution I would give you is this. Don't market yourself as an office that does a complimentary evaluation and then submit a code that says it was an evaluation code, okay? Because you're going to have patients ask, why did you bill my insurance? You said that the consultation was, bill out that code and look at it as your treatment planning code, post-diagnostic, where the doctor puts the treatment plan together. But can you bill it? Yes, you can bill it. If they have an ortho benefit, could come out of their ortho benefit. You just never know. But you're going to take one of those exams away from your dentist when you do that. And I know Dr. Robley is interdisciplinary treatment. I've known him for years. That's the only thing that I would caution you for.
Let's see here. If you give the patient a discount do you bill the full fee or disclose the discounted rate? How is it handled on a typical claim form?
Okay, good question. Because insurance tells you to bill your fees. You should always bill your fees to insurance, okay? The only discount that you don't have to disclose to insurance is a pay in full discount. Other than that, you need to let them know that you've discounted that treatment. And the way most systems are set up, you know, I know other consultants, listen, dentistry is different than orthodontics, okay? We have a course of treatment. So when it comes to the breakdown, I break down my fee, the office fee, and then I let them know that a courtesy of X amount of dollars was extended in a remarks section, resulting in a bottom line fee of this. But pay in full on the patient's part does not have to be disclosed.
Are we allowed to charge more than twice the amount of the in-network benefit? I've had customers call saying that their insurance companies are telling them that we have overcharged them for in-network services. How would you respond to that?
Well, when it comes to fee transparency, that's why provide your fee, tell them what's not allowed in terms of the discount that they'll get, and then look at the bottom line. With that transparency, when their EOBs come through or when they tally everything with their EOBs, it should basically be what it is you're charging them. You cannot upcharge Invisalign, clear brackets with MetLife, Delta Dental, some of them may follow. But you should look into that if your patients are telling you that. The other thing I will say is this. Most offices will break down their submission based on the way they feel they earn their fee. Patients look at their payment plan and they see their payment plan different than what the EOB numbers come through. And they're thinking that you're doing something you shouldn't be doing. Those EOBs are never going to match your numbers because the patient's payment plan, in terms of their mind, is basically with the insurance removed from it, the benefit removed from it. But I would say look into those things, because the last thing you want is an insurance to be on the radar of an insurance company that decides they're going to audit you, because they'll come into your office. They will go through years worth of claims with the situation they have, and you will be refunding money if you are overcharging your network.
How would you suggest a practice to decide which networks to be a part of?
Again, I would say, well, I look at it this way. Obviously, you're going to look at the allowances they give you, and how much of a discount you have to have. You might have an office that has, don't look at a comprehensive fee if you do a lot of phase ones. Make sure you're looking at the codes that you have for those. The other thing is definitely look at your options for indirect participation. The other thing I would do is go back and look at your discounts. What are you giving to patients if you're out of network? It could be a shock. To many doctors, it's a shock. But the goal of going in network is so that you're not losing patients, that they're coming through the door, as a result of their in network. And, I follow referral patterns in offices, and most patients won't tell you they're coming to you for their insurance. They've word of mouth, or their friends come, or this or that, but their insurance could have been an influencer for them. And, if you're running a great practice, where patients, they're going to lead with their heart and not their wallet, you don't have to worry about that. But I would say the other thing you have to worry about is if you're in an area where you have a very large employer who employs a large population and they're under a certain plan. I live in the Washington, D.C. kind of metropolitan area, and government, the offices in this area, you can't not work with federal plans because everybody works for the government.
Is there a tried and true way for me to know what a patient's benefits really are without spending hours on the phone verifying insurance information?
Well, yes. There are certain plans that you can go to their website, you can request a fax, and it's pretty predictable. MetLife usually has pretty good disclosure. I've heard my coordinators tell me that Delta Dental is actually saying, did you get a fax online? And they won't even take your call unless you've done that fax online. Look at what is the trend in your office. If you have a lot of underpays and you have some of these scenarios going on that I just talked about, you can't afford not to do the verification. You know, again, you can't undervalue a service like OrthoFi in terms of insurance verification, because they're in the trenches for you. You know, time is money, and they're in the trenches to you with your service. It depends on, you know, what it is you're doing. But I do hear that. I hear that COVID, post-COVID, it's worse than ever. And you look at it. Can you get away with it? You know, is my bottom line, I'm getting the benefits I think I'm getting, and I'm not spending all that time on the telephone. But if you're not, if you have underpays, if you're missing certain things, you know, it's a necessary evil for the most part. So I would say, look at your trend first. Can I get away with it? You know, I've seen offices where, you know, for lack of not having the information ahead of time, they do verification afterwards. But I'd hate to tell a patient they have something and then turn around and come back and tell them that they don't. Okay. So yeah, man, I wish I had a magic ball for that, you know, and something that we could all change. It's a burden.
Yeah, you know, obviously, you know, it's a shame, you know, as a little plug for OrthoFi, and that's something that we obviously do to help our practices. You know, we verify nearly 40 points, you know, in the process for patients to verify insurance, so that obviously you're not needing to dig around and not leaving anything out there that might get missed. And obviously, you know, really one of the main things that we try to do, and if you look at, you know, you showed the slide earlier around statistics around same-day starts, and you know, our practices have more than two times the national average same-day starts, and a lot of that comes from grooming the patients on the front end, so that, like you said, you don't have to follow up of like, we don't really know what the insurance benefit is when they step into your office for the first time. You know, we've verified that insurance ahead of time, so that you really have everything you need to give them the information they need to get started right away. So, question here from Raven Scott at Morris Orthodontics says, I've been utilizing the 80/70 code for about the last 6 months, and so far I've not had an issue. What do you expect will happen about this?
I've been using that 80/70 code for more than 20 years and rarely have an issue. You know, I think it could depend on plans, you know, where they're funded or certain trends. You know, I see on social media that people do have that problem, but I can tell you my experience, and a lot of offices will say not a problem. With these CDT codes going away for the interceptive, you know, that those mid-level codes, insurance carriers, it's a business, and businesses are out to make money. And I hope that our industry isn't taken advantage of. You know, I hope that they will visit those limited codes, but I'm going to push an 80/70 for as long as I can push an 80/70 for the simple reason I've got a higher allowance if I'm in network. So go for it for as long as you can.
We've had a couple questions around this one, but this is from, let's see, Tim Reese at Declaration Dental, as well as Diana Schaefer from Byrne Orthodontics, who's one of our OrthoFi clients. But we are in network with Delta. We've always umbrellaed submissions for ortho. Unbundled submissions for ortho. Delta has started sending back denials for pre-ortho treatment, such as films, models, photos, and D0160. We were unable to charge a patient with 100% discount because treatment must be included with D8080. So what would you advise there as far as trying to help it so practices aren't having to write off you know, unpaid amounts?
I don't hear that with Delta. The 8660, yeah, it's hit or miss. And it could be the cross coding that they're coming up with different rules, you know, within plans or carriers. But you have governing on two different levels, carrier level and plan level. And exclusions on plan level can be negotiated, you know, by employers when they buy the plan. It sounds to me like you've got to ask those questions during verification. Okay. So, The other thing I would say, if I can say anything, is submit your diagnostic exam or diagnostic codes on a different claim form than you do your comprehensive code. Sometimes that pushes things through, easier. You have, they don't disallow things, and you're not doing anything that you shouldn't be doing, but just the fact that it's on a separate claim form can make a difference. Good luck.
Let's see here. This one is from Heather Wall at Pediatric Dental Specialist. If the secondary is what matters in the NDB plans, because the primary could be standard, which doesn't matter if the secondary is non-dupe, correct? What if the primary is non-dupe, but the secondary is standard?
Coordination will only apply to a secondary, okay? Primary is going to stand alone. If it's a non-duplication, their primary, it's irrelevant. So coordination only applies to your secondary carrier.
Let's see. Is there any way to prevent an out-of-network carrier from sending the subscriber the payment? It's like the carrier forces you to enroll with them, or payments could be delayed due to it being sent to the carrier.
If you're out of network and a carrier will not send you payment, I can tell you it's a bureaucracy if you try to get through it. Even if you had that subscriber insist, chances are you're not going to turn it around. So I would say it is what it is. Don't pre-credit those benefits, but do tell them what their out-of-pocket is once they are reimbursed by their benefit, okay? That has become very helpful in my offices when, you can't present them their out-of-pocket for the payment plan, but you can present them their out-of-pocket in terms of their overall investment. So try that. That might be helpful to you, but I don't expect you'll turn it around.
This one is from Sharice Davis. I'm nervous about the new D8060 not being used in 2022. How should we proceed? Should we just bill D8070, but nervous about quoting benefits on phase 1 treatments now?
Well, I would say if you're in network, you've got to go to your fee allowances. The other thing is, now's the time to contact your carriers and ask for updated fees. Again, I've not had any feedback as to what carriers are going to do. They're notifying providers that those codes are going away, but I've not seen any chatter on social media that anyone's gotten it, and I certainly haven't gotten it. And I do a lot of communication with companies like 5 Lakes, which, they're inside the offices of carriers all the time, and there's nothing to report from them yet. So I don't know. We're all nervous about it. I really wish that there'd have been more awareness that this was happening, outside the AO, because it greatly affects in-network providers. So do your homework. You can't just say, I'm going to go to this code. You have to go back. And you also have to look at your treatment. Sometimes small matters in terms of the way you manage treatment can make a difference with coding, which I can't just say across the board. That's something that, I've got to work through with a doctor.
A question here. So my financial coordinator told me that the initial EOBs never tell her how much the insurance will pay overall for treatment. That makes no sense to me. Can you advise?
Yeah.
Is there something being missed? And we use Dental Exchange right now to confirm benefits.
She's correct. They don't. And it's really confusing. And it's totally confusing for patients and parents alike. They kind of use their own formula, in terms of how they're going to pay, how they calculated, what they allow. The numbers never make sense. If you want black and white, you have to do a pre-auth. And I've said to my offices already, if that's that important, shoot the pre-auth off, wait a day or so and shoot your actual services off. The pre-auth should go through. It should tell you exactly what they're going to pay. And the statement of actual services will go through the system, a number of days later, and it'll activate your claim. But yeah, it's frustrating. You ought to try to teach it. How do you take a new person, onboarding them with insurance and teach them how to read EOBs? Makes no sense.
If a patient is an RPE ready for phase one, can you enter the contract and start it?
If a patient is an RPE and ready for phase one, can you enter a contract and start it? Sure, you can enter a contract into your system anytime. You cannot submit the insurance until that RPE is placed. Okay.
Let's see here. Isn't it true that that you should charge insurance for a consultation if you aren't charging the patient 50%? Insurance is here, let me just read that, start that again. Isn't it true that you shouldn't charge insurance for a consultation if you aren't charging the patient 50%? Insurance has a couple years to request the overpayment. So do you suggest refund payments to patients when they switch carriers to treatment and end up with a credit balance?
Oh wow, that's a long question. Do me a favor, please. I hope you check my email. Email me those questions so that I can kind of break them out for you. But the rule of thumb is you can't bill insurance for something you don't charge a patient. If you're in network, we're looking at everything we do with that patient. But my rule of thumb for evaluations is this. Most orthodontists say there's no charge for your evaluation or it's free, and you should not bill that code to insurance. That's just me.
Let's see, if you go into contract with Carrington, like some sort of umbrella, do you have to cancel individual contracts with Cigna, Gaia Guardian, and United Healthcare?
If you're looking to go with those plans indirectly, that's a question that I would inquire about. Call 5 Lakes Pro, get on the phone with someone who's familiar with those situations and ask. There could be a sequencing that you have to do with it, but you absolutely can drop your direct participation. Whether you can turn around and go indirect with that immediately, I'm not sure. I'm not sure if there's a time frame there, but 5 Lakes Pro would be your source for those kind of questions.
Let's see. If you file the 8070 for interceptive, will you still be able to file on the same policy again when the patient is ready for phase 2?
Yes, absolutely. If they have a benefit remaining, and they're on that same plan as they come through for phase 2, you can. What you have to worry about is what you submitted for phase 1. If you submitted an 8070 and they have a situation where you can't use more than one comp code, you could have a problem. You might have to adjust your initial claim and go back down coded or whatever. But yeah, you can. Just make sure there are no time limits, waiting periods between phase 1 and phase 2. And email me your scenario and how it usually flows in your office, with the way you go into phase 1 and the period of time between phase 1 and phase 2, and then how you submit. I'm happy to look at your situation individually and tell you my thoughts on it.
I know we only have a couple minutes left, so we'll answer a couple more that have been trickling in, and then, like I said, we will absolutely, Tina, I'll follow up with you. We can kind of sit down and go through all the rest, and we'll use it as a follow-up in an email to everybody next week. When should I reach out to carriers about changes in plans and in-network fee discounts?
I'm not sure if I understand that question.
When would you recommend reaching out to carriers about, like, if they're changing plans or in-network fee discounts, or if they're, I guess, like contracting with networks, like if they're talking about their fee schedules? Like, when would you recommend practices kind of talking to carriers about those fee schedules?
Well, I think that probably what you should do is know, like, when you can. You can't revisit a carrier if you're in network. They'll only talk to you about increasing your fees or anything like that, at certain intervals. Sometimes it's 2 years. You can't get a fee increase for 2 years, and you look at that. A lot of times the recredentialing time frame corresponds with that time that you can ask for a fee increase. I think that's the question you're asking me.
Let's see. Do you see more carriers not allowing assignment of benefits to the practice if they are out of network?
I would say that 90+% of carriers will pay an out-of-network doctor. The ones that I find are like certain Delta Dentals, certain state type Delta Dentals won't pay out of care, out of network. They'll go to the subscriber. Blue Cross Blue Shield in some states will not pay a subscriber if you're out of network. It's kind of like big commercial plans like that where I'm finding it, but it should always be a question that you ask. On my verification form, I have, we're out of network, and one of the questions is, will they pay, will they assign benefits to our office?
And you hit on this a little bit, but just in case there's any confusion, when we get more funds from insurance than we expected from pre-authorization process, is it legal to transfer the excess payments to the patient's contracts? By doing so, it may appear as a credit balance of account was paid in full. If that happens, can we refund that amount to the patient rather than refund the insurance company?
Yeah, good question. A true overpayment of insurance is when insurance makes an error paying you a benefit. Okay, that is what they'll ask back for. Sometimes it could be years. There are statutes when it comes to time limitations when insurance, state by state in terms of insurance asking for a payment, retracting a payment, but there's also a clause with those that says unless it's a coordination of benefits situation. Okay, so it kind of gives them free reign. I tell my offices this: at any point you receive more than you expected to receive, you have to look at it. Okay, look at it before you, certainly before you refund it. I've had offices that have written checks sent to patients only to find 3 months later that they refunded somebody's payment that was on that patient's ledger that should have never been on that ledger. So look for any reason that you might have gotten an overpayment. Are you billing multiple codes? Did they take something out of dental, and that's why you got more than what you thought? But you should try to figure out if it's a real increase in terms of the benefit payment that you got. So there's not one single answer to that question, but don't rush to refund patients, okay? And if you're getting a lot of overpayments and you're moving it around between patients and insurance, look at what it is. Why am I having this trend? I see a lot of offices, they're unbundling, they're billing records. Records are coming out of dental benefits, so they're getting payment on top of ortho benefits, and that's what increases it. So you kind of have to look at what you're billing out to insurance.
Awesome. So I know we are over time. Again, I want to thank everybody for being here. We will absolutely follow up with any of the questions that we missed. We want to be respectful of everybody's time. I know that we really appreciate everybody being here. So obviously, if you for all of our OrthoFi clients that are here today that joined us, thank you for being here. OrthoBank clients as well, thank you guys for signing on today and spending some time with us. If you're not using OrthoFi, we'd love to chat with you. We'd love to share a little bit about what we do, see if it's the right fit for your practice, talk with you about some of the things we can do to help you, streamline some of the things you're doing in your practice, help you maximize some of the benefits, maximize some of the reimbursements you're getting with some of the processes we have, and also help streamline your patient acquisition process. So we're doing a promo right now. If you do a demo in October, just do a demo with us. It takes an hour. I promise you it'd be a good use of your time, and you get a free free $50 Amazon gift card. You can schedule by just scanning that QR code with your phone, or just go into startmoresmiles.com, and you can schedule a demo straight from our website. But like I said, I promise it'd be worth your time and something that we'd love to do, and just share more about how we might be able to help your practice. And then again, to do a deeper dive with this, November 18th and 19th, we're having everybody in Denver. We're flying Tina out. It's going to be a party. But we are so excited for this course. We know there's going to be a lot of value. So we're going to be sending out some more information. We just sent out an email about it earlier this week. We'll send to everybody on this webinar some more things. We're trying to finalize the agenda and things like that right now, but we're going to have kind of a welcome, happy hour thing on Thursday night. And then we're doing a full, like I said earlier, deep dive into all these things, really to help you be successful when it comes to your insurance and your practice, all day on Friday here in Denver. So, on Friday, breakfast and lunch will be included. And like I said, I think it's really going to be a really valuable time for your practice. So whether it's your doc coming out or send an insurance coordinator, well, again, if you're an OrthoFi practice, OrthoBank practice, or if you don't use either one of us, it really doesn't matter. This is going to be really helpful. So we'd love to have you come, and there's a QR code there. It'll take you to the site to register. And if you use the promo code OrthoFi, you save 15% on your registration. We're going to keep that up, for the next weekend, next week or so. So, it's kind of an early thing, but we're only offering it to the people that are on this webinar. So thank you for being here. And, Tina, any last words from you before we sign off?
Thank you for having me. Everyone who attended this webinar knows that you don't have an easy job inside an ortho practice, managing the insurance, but it's workable, so workable. We just have to do our homework.
Awesome. Well, thank you guys again. Tina, thank you. This has been excellent. Appreciate everybody's engagement, asking a lot of questions. Like I said, we will absolutely follow up with anything that we missed. And the recording we'll share out probably at some point next week after it's done, downloading everything like that. So again, thank you all for being here. And if you have any questions, please feel free to email us at marketing@orthofi.com. We will make sure to sync up with Tina and sit down with her to kind of help go through and answer all these questions for you specifically. So again, join us in Denver in a couple weeks. And with that, I hope everybody has a wonderful weekend, and we'll look forward to hopefully seeing you soon. Bless my heart.